Good afternoon, everyone. I'm Dr. Tavares, a clinical advisor to the Pathology Reporting Project, and on behalf of Cancer Care Ontario, the Partnership, and the Canadian Association of Pathologists, I would like to welcome everyone to today's educational session on the CAP checklist for brain and spinal cord with Dr. Jansen. Before I introduce our speaker and we formally get underway, I'd like to take care of a few housekeeping items first. Number one, today's presentation will be approximately 90 minutes in length and will include approximately 60 minutes of presentation time to be followed by 30 minutes of question and answer. Point two, the session is being recorded and will be made available to all participants via email links once the recording becomes available. 3, both live presentation and the recorded presentation are eligible for CME credits upon the completion and submission of evaluation form available electronically. The information is accessing the evaluation form was provided in the notice for this session previously distributed. Please note, CME certificates for each of the CAP checklist educational sessions will only be issued for 1 month from the presentation date. Recorded sessions will remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. Go to the session notice for the exact deadline dates. Fourth point, please note that everyone's line has been automatically muted for today's presentation. Fifth point, due to a large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you are having difficulties accessing the WebEx portion of this teleconference, please call the WebEx support line at 1-866-293-3239. I'll repeat that number again, 1-866-293-3239. Sixth point, we encourage you to submit questions at any time during the presentation using the chat feature. Instructions on how to use the WebEx chat window, please refer to the documentation previously distributed. During the question and answer portion of the presentation, in order to avoid question collisions, I'll pose the submitted questions on your behalf as long as time permits and in the order in which they appear. In the window, please include the following information: your institution's name, the individual posing the question, and the question. Housekeeping items completed. It is now my pleasure to introduce Dr. Jansen. Gerard has been Division Head of Anatomical Pathology since 2007 of the Ottawa Hospital, associated local and regional functions. He has transformed the pathology service in Ottawa to become more subspecialized, and has also played a major role in modernization of their pathology laboratory information system, went to back barcoding for all specimens, modernizing and automation of the immunohistochemistry laboratory, and development of telepathology. At the clinical level, he is joint with Dr. John Wolf, responsible for the caring of the neuropathological service to the neurosurgical and neurological departments of the Ottawa Hospital, both at the general campus and the civic campus regional consults. He has his research activities are focused on Creutzfeldt-Jakob disease. After working 20 years in the epidemiological, clinical, and neuropathological aspects of this disease, he belongs to a very select group of collaborating international researchers who devote part of their time to this condition. Activities at the Public Health Agency of Canada, University of Ottawa, with the National Reference Neurologist for CAD, are focused on the clinical aspects of the surveillance for Creutzfeldt-Jakob disease. He is one of 2 principal investigators of PAC's CAD surveillance system. His educational activities at the University of Ottawa are focused on the pathological aspects of Jakob-Creutzfeldt disease and teach neuropathology in general to the medical students, elective students, and in pathology, neurology, and neurosurgery. So with that introduction, I hand it over to Gerard.
Mo, that was an extremely kind introduction. I was thinking that we were going to discuss a checklist on Creutzfeldt-Jakob disease, but that would not. And actually, everybody is probably very happy that we're doing this by telepathology today, because I got a little bit of a bad cold coming up, and otherwise I would infect you all. So without further ado, we're going to go through the presentation. Let me see. I think my presentation is a little bit slow to move forward. First and foremost, disclosure information. I have a couple of financial relationships. First and foremost, I'm an employee of the Ottawa Hospital, which I am sure has nothing to do with this decision and does not in any way influence my views on the cancer checklist. Also, part of an advisory board for our LOS system. I will show a few snapshots of that LOS system, but it has further nothing to do with the cancer checklist per se. Objectives. What I would like you to take away from this is to become acquainted with the flow and required elements of the brain and spinal cord electronic cancer checklist, to be aware of the general differences between the brain and spinal cord electronic cancer checklist and other ECCs, because they're quite significant, to be aware of the quirks of the brain and spinal cord checklist, and to be informed of changes that the review panel will propose to CAP for the spinal cord ECC, and so be aware of future plans for the review panel to work with Canadian Association of Neuropathology to make this not just a small group event, but actually to be something that's borne by the large population of neuropathologists in Canada. As Dimo said, questions, submit those questions please. Here is that slide reminding you that it will come up later on again, but I'm sure you can find all the information of how to use that chat. So, first and foremost, this is about the 2010 ECC. Actually, very recently, the 2011 modification of it came out through CAP, but currently we're discussing the one that was available for 2010. First thing of action is, of course, what kind of cases are to be put in a synoptic report. First and foremost, all primary brain tumors and spinal cord tumors, including the recurrences. Further, pituitary tumors, including adenoma, nerve sheath tumors. It also includes primary CNS lymphomas, but it excludes all metastatic tumors. In workflow, all the elements in the ECC, there are 11 elements. 4 are not required fields. First was history, and actually specifically to previous tumor and familial syndromes. One is specimen type and procedure. Third, specimen handling. Fourth, specimen size. Fifth, locality. Sixth, tumor site. Seventh, that is actually the meat and potatoes of the whole ECC. The histological type and grade. Eighth, WHO grade. Ninth, the margins, but only for malignant peripheral nerve sheath tumors. The 10th, ancillary studies, and the 11th, comments. So, discrepancies with the other ECCs, because from these elements we could already deduce something. One is that also benign tumors are in the brain and spinal cord ECC. That we see mostly not in the other ECCs. Obviously, the fact that the brain and the spinal cord is in an enclosed space, and benign tumors can behave malignant in a clinical fashion has helped in coming to this notion that also benign tumors should be in this ECC. It's all primary, so also the recurrences. That is also different from the other ECCs. There is no interest in any type of growth pattern as in some ECCs such as GI-oriented ECCs is. There is no interest in ingrowth in structures, as usually in TMN classifications is seen, and therefore in most ECCs is found. No interest in margins except for malignant peripheral nerve sheath tumors, and it's obvious reasons, because margins are very difficult to treat or even assess for brain tumor. No status, as it's not applicable, and for also no TMN status. So there's quite a bit of differences. Excuse me. When you put an ECC in for a case where this is applicable, you start with a case where, of course, this has to be applied. And here we see a screenshot of when I were to enter my ECC in a case. And these are consistent of drop-down menus as everybody has them. It's played into a case, as you see it here in our LAS, with on the left-hand panel showing what kind of slides we have, and in the right-hand panel it shows us basically the information of this patient and also where we will drop the synoptic report. Report we usually place in Ottawa in the microscopic description, just like many other instruments. And when we go and do that, we look at the synoptic report. As I said, we have these drop-down menus. Now, I'm not going to go any further with our own system and just be switching over to the paper version of the ECC just to make it a little bit more clear for everybody, because I'm sure that everybody's system looks a little bit different. Element is history of previous tumor and glio syndromes. Again, this is a not mandatory field. Only 3 inputs possible: none known, known, specify if known, and specified. With the review committee, we decided that this information, as it was supplied by the neurosurgeon, that is the only information you usually have. For some of us may have an medical record system available where we can trace some of this information, and possible, then that is wonderful. But many of us will have to do it with the information just supplied by the neurosurgeon. By the way, the little picture below is of a nucleate ganglion cell in a gangliocytoma. It's less boring. Specimen type of procedure is a mandatory field. Of opening there, open biopsy, resection, stereotactic biopsy, other, and then specify or not specified, again as supplied by the surgeon. Now, of course, when we a needle biopsy, we do that. It's usually a stereotactic biopsy. From our material, we can also deduct some things of this. Handling is also mandatory and especially important field, and also the committee felt that this was an important field to rating, because the information contained here tells you 2 things. One can tell you something about the consistency diagnosis. For instance, if we only have a frozen section and no other material available of this case, then in that case it can tell you that many diagnostic features are not all so apparent, and there could be doubt about the grading system. This specimen handling, one has to enter all that apply. So, for instance, if you do a smear preparation, a frozen section, and have tissue for routine permanent paraffin sections, you have to touch 3 boxes and fill them all. Specimen size is not mandatory. However, it can be quite handy to fill this in, especially when later on requests come for doing molecular testing, etc., or for trials. Dimension is the greatest dimension of the largest piece. That's how we took that. Middle dimensions are mostly interesting if we have an aggregate size, such as in ultra-aspirated material. Laterality, obvious, left, right, bilateral. peripheral, not specified or not applicable. Again, as information that's supplied by the surgeon. In the lower corner you see a nice picture of a nucleus in a pleomorphic xanthoastrocytoma. Primary tumor site. This is again a mandatory field and information as supplied by the neurosurgeon, although when you have the opportunity to look up a scan in your medical record system, you could help yourself to extra information. There are several groups that have to check all that apply, and most of these have an additional specification in subfields. For instance, skull, there is subfields as sphenoid ridge, etc. The dura has subfields, the left meninges, the subdivision brain and cerebrum, especially in the lobes, and we also have further cranial nerve, ventricles, brain stem, spine, spinal cord, spinal nerve roots, and then unfortunate duplicature cranial or peripheral nerve. And you can see we already have a cranial nerve. This has been corrected in 2011 version, where there is cranial nerve and loose peripheral nerve. But again, that is not the version that is currently being used by CCO. Again, others are not specified. There is a second field to be filled in, one that I always forget to fill in, is additional sites involved by tumor, and then you get the second list, the whole list again to fill in. A little bit double. Come to the most difficult part. It's called type and grade. This is the WHO classification of 2007, which has the categories, as you can see. Most importantly, astrocytic tumors, oligodendrous glial tumors, astrocytic tumors, and ependymal tumors, all forming the gliomas, a large group, and of course the other large group that we have, which is of the meninges and meningothelial cells. Now, those two groups I will especially talk about a little bit further, because there are a couple of issues there. Come from the fact that we had 4 classifications from 1997 to 2007. Now you only see 3 volumes here lying on this picture, because I lost one volume somewhere along the way. Maybe somebody lended it off me or something. There are many changes in those. If you compare the 1997 volume to 2007, especially gliomas and the meningiomas, we will see quite a bit of changes. And we will see also, of course, new entities. One thing that we came up that we were not completely happy with was astrocytic tumors. These are divvied up in the list of WHO with a first tier, which is in this case astrocytic tumor. Then we have a second tier, in this case diffuse astrocytoma, is the grade 2 tumors, and then a third tier. We look at that divvying up in the third tier. We have fibrillary astrocytoma, protoplasmic astrocytoma, and gemistocytic astrocytoma. When we were discussing this in the review committee, felt that probably none of us actually looked at diagnosis of a protoplasmic astrocytoma in a very long while, if ever. And if we were to then know something or classify something in the CCO ECD, we would probably tick diffuse astrocytoma. However, if you do that, you basically say that a gemistocystic astrocytoma is also one of the possibilities, and all in the committee felt completely happy with that, given that gemistocystic astrocytoma in the past had classified as a WHO grade 3 tumor rather than a grade 2 tumor. So still quirks that need to be figured in the future. Stoma is another issue. It has 2 childs, if you like. Glioma is the parent of giant cell glioblastoma and gliosarcoma, and almost makes it look like there are only 2 options to give in a glioblastoma. Unfortunately, that's of course not the case, because giant cell glioblastoma and gliosarcoma together make less than 5% of all glioblastomas. It solved in the 2011 edition of the brain spinal cord ECC from CAP by making the giant cell glioblastoma and the gliosarcoma no longer a child of glioblastoma. Basically, they're of the same line, and they can now choose between glioblastoma, giant cell glioblastoma, and gliosarcoma. However, not in our current version. This issue, what has been done is to make a third tier in all classifications not mandatory. So if you check the second classification, you're kind of good to go. You don't need to take one of these third tiers. Actually, in a way, indicate glioblastoma by itself. Another issue is small cell glioblastoma. This is currently not part of the WHO 2007 cases, but many neuropathologists start to recognize this as a separate entity. And one could argue that this should actually be one of the options in a glioblastoma. And just for, I added a picture of a small cell glioblastoma. As you can see it over here, it almost mimics a small cell carcinoma. Just the microvascular proliferation, but the mitotic activity and apoptosis is almost a similar look. We have a lot of GFAP positivity and P53 positivity to kind of separate it from that. So, dendroglial tumors also has an issue in the sense that we now have recognition of glioblastoma with oligo features, which is oligo HO grade 4 tumor. And you could argue that this is part of the oligodendroglial tumors or of the glioblastomas. But since it is not part of the 2007 WHO book, it has not been included in the CAP worksheet. Just an example here, and with oligodendroglial features, with a lot of microvascular proliferation being present, and geographical necrosis present, and this is a glioblastoma with oligo features. The great advantages of so many different versions of the WHO book is that we get new tumor types that are being added, and one of them, for instance, is the PGNT, which is WHO grade tumor. And just for the light of the viewers, I've of that. At least if the system will want to advance a lot more, a little slow. Excuse me. We see nice papillary structures, oligodendrocyte-like surrounding cells, and between larger neuron-like cells lying in between. Some of the papillary structures contain vessels, others not. This is an adult, one of the cerebral hemispheres. Tumor is GFAP positive. Some of the larger cells are neurofilament positive and synaptophysin positive. Excuse me, my cold is split a little bit. Then the last group is tumors of the meninges. And as you see, it is divvied up in grade 1 tumors, grade 2 tumors, and grade 3 tumors. And there are a couple of issues there that need to be discussed. What is lacking in this distinction is angiomas with ingrowth in the brain. It's been recognized as WHO grade 2 I think this should have been added to the list. We can use other and classify it as such, and I think that's something we should do. Something is mixed meningiomas. Meningiomas that have part of a benign meningioma with WHO1 criteria, maybe with parts of tumors that have higher grade. And in this case, it is mixed with a tumor with rapid aspects, eosinophilic very inclusions, with like cell borders of the cells, large nuclei with large nucleoli. And this is a WHO grade 3 tumor, and this WHO grade 1. You have to look at how much of what, and that is very difficult in the WHO book actually. And for that reason, it's also very difficult to put this actually back into the ECC. The panel discussed this and felt that this is something that you really have to put down in comment sections. The vimentin in this case, where there's also very strong cellular vimentin in these inclusions, you see. So, let's take away from this the problem that we have with the gliomas and the meningiomas, if there are non-standard features or new entities that are recognized, use the comment section at the bottom of the report well. And there are things that do not fit the current classification. Use other classification and grade that manually. The 8th part is histologic grade. We can here put in WHO grade 1 through 4. This is only handy if you cannot determine a grade before because it didn't fit one of the criteria of the tumors. And otherwise, unfortunately, this is quite superfluous. And is something that will be brought back forward to remove. Compare ECCs, this is quite simple for the brain and spinal cord ECC. Filled in for malignant peripheral nerve sheath tumors. And then we fill in cannot be assessed, margin not involved by tumor, margin involved by tumor, and then specify. So simple and actually, and I think our more general pathology colleagues will be quite jealous at the neuropathologists. Studies, so not a mandatory field. Not in immunochemistry, and then there is in this EC space for the 1P and 90Q molecular study. Others have not been added right now. One is additional pathological findings. They are being used for non-standard features, but also features that do not affect grading. But some you could also here anything that is elsewhere in the brain around. So like here, a Lewy body in a neuron adjacent to tumor tissue. The feature, but maybe something to enter if you find it. Common used for the same as 11, but we felt it was best used for features that affect grading situations or to clarify information to a clinician. To the end of our ECC, I've filled in like to do. Probably everybody else has to save their changes somewhere with a button and on. It gets entered into the text, and of course, text needs to be checked. After that, you have to do with the rest of the report what you need to do. Now, what you see here is that I added for myself a little histological description. And reason Excuse me, I can't turn these overhead messages off. The fields are added because what the EC does not supply for is a place to show how many mitotic figures are present, if there was microvascular proliferation or necrosis in cases. And these are of importance because the cell grading system has changed over the years, and if we want to remain up to date and compare an older tumor to a newer, one would want this information to be there. It's not mandatory in any way, but personally I find it a good use, and I know that my clinicians really appreciate this. And diagnosis has to be added, and the case has to be saved and sent out as one would do with any case. So I said already a couple of times that we had a brain spinal cord ECC review panel. That was called together in early fall, in September 2011, composed of Dr. David Munoz, Dr. John Rossiter, Dr. David Hunt, and myself. I'm very grateful of the other three who helped a lot. We discussed this 2010 ECC in Toronto in October. Made some suggestions for improvement that will be submitted to CAP. And what we want to do is bring this brain and spinal cord ECC in as discussion material for future CAAP meetings, so that together with our entire group and not just Ontario, we can discuss these ECCs. So actually, suggestions for improvements are borne by the whole society. So what we'll do is over time look at the frequencies of entries that are free-form, and especially ancillary studies leads itself for that. Because what we can then say is to CAP, maybe we should add these studies as ancillary studies to the list, rather than have a pathologist retype this. Some suggestions that we've made is add metastases. Metastases are an important part of the neuropathologist work and tie into the ECs elsewhere. The second one, what we found very annoying, was that elements in drop-down menus were not ordered by the frequency in which they occur. I feel that CAP and MCO has an important place to play in this, to order these by frequency and not the vendors. The vendors will always do what CAP will want them to do, and they will probably not out of their own accord look into frequencies of answers. Not that history benefit from adding previous tumor and prior tumor and adding treatments, including steroids. There should be added debulking, and in histological type we wanted to fix some child relationship. For us, especially want to add functional criteria such as mitotic frequency, necrosis, microvascular proliferation, sheet-like growth, at least in the angiomas, etc., so that basically it reflects the basis of the grading scheme rather than the grading scheme by itself. That lymphoma should probably follow the lymphoma ECC, and adenoma, which would consider using a separate ECC that has been developed. We would like to consider the WHO grade for removal, and for ancillary testing add already the Ki-67 and IDH1, which are widely used. Suggestions. Currently we have the CCO and CAP ECC as it stands. We'll have to work with that. So with that, the presentation is a lot shorter than usual because, of course, we miss a lot of elements to discuss, such as resection margins. But I'd like to invite you to ask questions, and please do.
Thanks, Rod. That was great. And we are envious of your resection margin category. So I wish we had it that simple in the other ones. But there you go. You win some, you lose some. We've got two questions. So I'll do the first one. The first one is from the CHA Hospital of. So this is French infant. Infant Jesus from the Gold. And his question is, should you include Cavitron material?
That's a wonderful question from Peter. Should you include Cavitron material? Well, of course you can include it in the checklist, but frankly, for diagnostic purposes, we all are, as neuropathologists and pathologists alike, we're hesitant in using that kind of material for a definitive diagnosis. If it's all we have, then that's all we will have and to do with it. But I'd rather use my my ECC and also my diagnosis in the end, be it based on other material than Cavitron material.
And the second question is from St. Michael's Hospital in Toronto, and it's from David Munoz and Kathy Stroitka. And their question is about a site. Where should meningiomas be located? Dura, left meninges, or brain?
It's something that Fitz and I discussed on that very day that we met, and he actually pointed that further out in the material that he sent back when we were discussing this. It's a very difficult discussion. I think in most cases it's attached to the dura, so probably we should call it dura. But the whole discussion about where it does a meningioma come from is obviously is a whole different ballgame. But I would go with the practical location of the tumor, where it's located most, and that's probably attached to dura. But that would be my point of view. I would like to share my point of view for a better one if there is available. We've
got a third question, and it's from Dr. Ross Surska. And the question is, do you report treatment response?
Report treatment response? No, we don't report treatment response on these. There's basically no space in this ECC for that.
So, do you think then, Gerard, like for example, in breast and the rectal cancer checklist actually have where the neoadjuvant therapy has been received or not? Is that worth maybe suggesting as an addition in the treatment before the surgery?
And one is that where we usually see this is in metastatic disease. For instance, what often happens is that these patients receive either chemo or especially radiation on their mat before the mat is resected. And those tumors, it would be very much beneficial. So if CAP would include metastasis for the future into the brain ECC, then we would certainly have to add to that a response, because that is especially something that the surgeons are and the radiotherapists are interested in.
David Munoz and Kathy Strike have actually sent sort of a question or a comment from your response to their question, and they say, I believe we should have a homogeneous response. To the meningioma question, where should meningiomas be located? So,
if he wants from me, if he kind of suggests that I have to cut to the chair, then let it be dura.
And we have a question from Lee Ank. If you have grade 1 meningioma with a small focus of high-grade element, how is this dealt with in the checklist?
Well, this is quite similar to what I was discussing with the right piece in an ordinary meningioma. what we did once, at least this case that I showed was not my case. It was the case kindly supplied by John Wolf, who was my partner here at the Ottawa Hospital. And what he did in that case, and I think he's probably right in doing so, rhabdoid tumor is a grade 3, and the ordinary part was no more than a grade 1. Given that it was a small part relatively, but on the null and also on the outskirts of the tumor, he graded it ultimately as a grade 2. Now, one would easily argue, well, if it's more than that small part, one should probably grade it a grade 3, and I agree with that. But I think one of the most important things here is to actually discuss this with your clinician. Such a case requires extensive discussion and explaining why grading scheme in these kind of situations is probably not perfect. Because I do feel that these patients require clearly more follow-up and more frequent scans. The patients will receive radiotherapy, and I think that's very justified.
There are no more questions, but maybe a comment here too, Rod. We've actually created an ECC committee, which is sort of a subcommittee of the committee that John Shrigley chairing, and that is part of, as we're closing down the implementation of the checklist, we're moving into the operationalization of the checklist, and the ECC committee is to get back from the pathologists in Ontario to be able to give it back to the AP if there are any concerns or additions or how we can improve it. And part of the ECC committee is also to review the updates on the checklist so that we can look at them, ensure that hopefully they're listening to the suggestions coming from the Ontario pathologists, and then make recommendations to the committee that John chairs as to whether we should roll them out throughout the province. And the other thing I'm trying to create also is a central repository for any suggested changes to the checklist from the ECC perspective. But I know you sit at the CAP level, and so for some of the more cases, I'm not sure how we can help you get some of those changes across. But I think you're actually at the CAP level, so just to sort of let people know that we have that. But also, if you've got any suggestions on how we can help you, maybe get some of those changes through to the CAP and hopefully implemented, CCO would be happy to do that.
Great, Timo. I actually think that in those kind of, especially this situation, what we should do is actually get that information through both channels to CAP. We're not like Canada and Ontario is not the largest in size, so maybe if they hear it twice, it's better than once.
Yeah. Okay. Well, I guess we'll be in touch regarding that. We've got another question from Liang. Maybe a follow-up. Thanks for your response. Read the mixed grade elements and the meningioma. But the student who was asking was mostly wanting to know how the synoptic report should deal with this. For example, is this a good time to use meningioma other?
Would absolutely do that. I would, as I said in my presentation, use other or use the comment section where you need it, because those kind of weird tumors just don't fit it. And if ultimately you feel that using an ECC would actually give wrong information, or at least appear to give wrong information to your clinician, and you would feel get the impression about a tumor, then just don't use the ECC. Use your reporting, because ultimately the most important thing is that we get the right information to our clinician and they act on the right way on it.
So that's from a question perspective. Gerard, I'll just want to say thank you on behalf of Cancer Care Ontario, Partnership, and the Canadian Association of Pathologists. I would like to thank you for a truly comprehensive, informative, and a very clear presentation today. This is our fourth session in the third series of the CAP checklist presentations, and we would welcome your comments and suggestions for ways to ensure these sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of your completed online evaluations. Once the WebEx recording of this presentation becomes available, it will be made available for wide distribution via links posted by CCO, the Partnership, and the CAP. Access to this recording will be available for review at your convenience and is not restricted. Reminder, both the live and recorded presentations are eligible for C credits, and in order to receive those credits for attending or viewing the educational session, you must complete an evaluation form for each session, accessed or viewed in its entirety. The link to the web-based survey has been included in the session notices distributed prior to each session. And again, just to reiterate, the CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation date. The sessions will remain available electronically for an undetermined period of time, but the CME certificates will only be issued for 1 month. So please refer to the session notice for the exact deadline. Our next scheduled CAP checklist educational system is February the 15th, 2012 on Testis, and that is Dr. Asli Yilmaz. And just FYI for now, we've postponed till fall of 2012 the bone marrow and lymphoma checklist. So that, once again, Gerard, a very big thank you for a wonderful presentation. Goodbye to everyone. Thank you.
Thank you very much. Bye-bye.